Gentlemen, you're all most welcome for today's session. My name is Mwanguzi Shadrach. I'm a doctor working with Mengo Hospital. I'm also a resident with the East Central and South African College of Physicians, abbreviated as EXAPO. And I'm privileged to be our moderator today. It's going to be an interesting afternoon because we are going to be diving into something very, very important to us as health workers, because we are faced on a day-to-day with patients who come in with difficulty in breathing. And so getting to know in detail what we are supposed to do all the way from the first interaction with these patients until when we save them from whatever has caused this symptom of difficulty in breathing is concerned. We are going to have experts with us this afternoon who are going to take on the different tasks of presenting the case, discussing the various aspects as we are going to discuss this afternoon. With me here, I have Mr. There are some of our presenters who are online, and we have some who are with us in the house. I'll start with experts within the house, and I'll give them an opportunity in just 30 seconds to introduce themselves. And then later we shall have the ones that are following online. I'll start with Mr. Joshua Ogwal. You're most welcome, sir.
Thank you so much, the moderator. Good afternoon, all. My name is Ogal Joshua. I'm a nurse working in Mwende Regional Hospital, and I work in the HDU. As well, I'm a BEC registered trainer. And today I'll take you through the nursing care of our case presentations. Thank you.
Thank you so much. And then we shall have Mr. Dennis. Yes, Mr. Dennis.
Good afternoon, everyone. Good afternoon, everybody. My name is Kalebo Dennis. I am an EMT with KCCA. I'm also a BEC instructor, and I'm so glad to be here.
Yes, thank you so much, Mr. Dennis. And then we shall have Dr. Patricia. Kindly unmute and introduce yourself. And after Dr. Patricia, we shall have Dr. Tracy. Dr. Tracy, if you're there, you could unmute and
Just mention to her that she.
Dr. Patricia, we are still unmuting your microphone. Yes, now you can talk. Sorry, I saw you were trying to talk, but we couldn't get you. Please introduce yourself again.
Good afternoon, everyone.
Good afternoon.
My name
to you.
is Patricia Bulakali, a second-year resident in emergency medicine at Mbarara University of Science and Technology. And I am glad to be part of the eco session this afternoon. Thank you.
Thank you so much, Dr. Patricia. And then finally, we shall have Dr. Tracy.
Good afternoon, everyone. Thank you for inviting me along to this echo session. I'm a SEED educator working alongside Patricia at Mbarara as well. So thank you. I should say I'm an emergency physician by training as well.
Yes, thank you so much. Dr. Tracy. So that's our team of panelists that we are going to be working with this afternoon to dive into this interesting session. I know I want to welcome the people that have so far joined in. You can see we have so far around 130 people that have logged in, and you might have expectations out there. I'm going to give an opportunity to around 2 to 3 people to give us your expectations during today's session. Kindly feel free to raise up your hand, and then we will help you unmute, and you tell us in just 30 seconds what your expectations are for this session. Yeah, if you have any expectation you want to share with us, feel free to unmute your microphone and share. Okay. Kato Rogers, what are your expectations? Let me have Kato, let me have Joshua Kawanguzi, and then I will have Lenia Morin. Yeah, you can unmute yourself.
Hello.
Yes.
Good afternoon. My name is David.
Yes, David.
Sorry, I was not among the list that you were suggesting, but I tried in, but the host was not allowing us, but now it can allow.
Yes, please, your expectations.
Thank you so much. I expect to know more about the ABC approach, and I would like to know how to differentiate between, if, for example, you are working with someone, maybe they have been talking and finally they collapse. I would like to know what you begin with, because I think that one might change from either beginning with A, which is the airway. So I would, by the end of this session, I know I would have known. Then again, I thought we were going to have like some CPD points added, but while I was registering, I couldn't see where the request needs us to put our number for CPD points. Thank you so much.
Thank you so much, David. Yes, Kenya?
End of session, sometime.
This is Joshua.
Yes.
Am I good to go?
Yes, Joshua. Yes, Joshua, can hear you.
Okay. In most of our limited risk setting, I wanted to know a practical in terms of emergency management protocols for patients that present with the respiratory.
All right.
Am I clear?
Yes. Did you have something else to say?
No, that is it. Thank you so much. I extend my appreciation to the team. Thank you.
All right. Thank you so much. So we are going to have our case. Today we are going to have a case presented. Along the way, we'll be posing this case to have discussions coming in. If you have any questions, if you have any concerns, kindly feel free to post them in the chat. We'll be looking at those questions, and where applicable, we will be airing them so the rest of the people can also follow through. And then we shall have videos to demonstrate some of the skills that we need us to learn this afternoon. Without taking more time, I'm going to welcome Dr. Patricia, our case presenter, take us through the next section of the presentation. You're welcome, Dr. Patricia.
Thank you very much.
Yes, you have the question.
Good afternoon, everyone. I don't know that I was trying to.
Dr. Patricia, kindly feel free to unmute and start the presentation.
Good afternoon, everyone. I hope I'm audible enough.
Yes, you're very audible.
Thank you very much. So this afternoon, I'm going to be the case presentation. The case presenter, sorry. My name is Donia Patricia Bulakali, and I hope this presentation will be very interactive for every one of us to enjoy and learn something this afternoon. Thank you. So this afternoon, we are talking about a 48 years old male presenting with difficulty in breathing. Initially exertional, now the difficulty in breathing is present at rest. He's a known HIV positive.
Just a minute, Dr. Patricia. Yes, you'll be patient with us as we have the slide projected. In the meantime, those of you that didn't get an opportunity to air out your expectations, please feel free to post them in the chat. Some of them might be responded to actively in the chat, and the others will be read out for our experts to deliberate on them. All right, Dr. Patricia, we are good to go.
Thank you. As I said, this afternoon I am the case presenter. My name is Patricia Bulakali, and I will talk about a 48-year-old man presenting with difficulty in breathing. Initially exertional, now the difficulty in breathing is present at rest. He is a known HIV positive, but not adherent to antiretroviral therapy for the last 6 months. He has a progressive dyspnea for the last 5 days, but no autopnea or paroxysmal nocturnal dyspnea. He has low-grade fevers, dry cough, right-sided pleuritic chest pain, has lost weight of around 5 kg over the last 2 months, denied any history of recent travel or known TB contact. To the pre-hospital team, what do you need to prepare to transport this patient? In terms of staff, equipment, mode of transport, documentation, and handover.
Okay. So colleagues, just a reminder, my name is Dennis Okalebo. I work with KCC as an EMT, and I'll be walking you through what we are going to prepare as as an EMT or emergency care provider. But before I walk you through that, there are things that I would like to prioritize on. Safety is very key. Safety is very key, and coordination is very important. We need to be in sync with the call center or the receiving facility. So one, we need to check if we have. We need to check how many. The ideal situation for EMTs should be 2 people in an ambulance. That is ideal, but cases where you are one, you can also respond to such a patient that we have been presented with. In normal situation, that is call center giving us such kind of a scenario, and then you have to go and respond. So you need to have yourself as the EMT or a paramedic, and then you need equipments. After understanding the patient that you're going for, of course, you need to prepare. We have understood that the patient is having difficulty in breathing and it's been progressive. So we need to have equipment that are going to help us manage what we have had, and also prepare for what we can anticipate. Okay, we're going to need oxygen. We're going to need oxygen cannula, and we are going to need to prepare for the worst case scenario. We're going to need ambibag. We're going to need an AED. We are going to need things for the worst case scenario, and then we are going to transport our patient. We're going to transport our patient, of course, in an ambulance. We are going to need to document, so we will need to obtain history using the sampler. Then to help us hand over, we shall need a tool, a handover tool that the most familiar in the EMS setting is the ICE bar, which is identify your patient, the situation where the patient is, and apparently the background that led to the situation, your findings and assessment, and the recommendation. And I would like to walk us through these things that I have spoken. So follow through. For starters, our patient is, as we have read it, as Dr. Patricia has already presented. So that is what I have in my mind as an EMT, or what you have in your mind as an EMT while you're going to this patient. So we have our tools together, we have everything that we need. So I'm going to walk us through what we are going to need to do for this particular patient. Like I said, safety is key, so you need to have some PPE. You've had the patient is having difficulty in breathing for the last 5 days and also feverish with dry cough. So we are going to need face masks. We are going to need gloves. That is obvious. We're going to need safety shoes and everything that you need to protect yourself. And then we go to this patient. So our first assessment, which is primary assessment, somebody say ABC, ABCDE. So we should get familiar by these things as we interact with the EMS teams. ABC, that is our primary assessment or primary survey. We assess our patient as that acronym helps us and guides us. I'm going to walk you through, and we'll be seeing the findings and what we are going to be doing for this particular patient. So our patient, when we reach the patient is conscious. According to the scenario, patient is conscious. So the patient is alert when we use our basic neurological check. That's the AVPU. The patient is conscious. So I'm going to rush to check on the airway. When you open the mouth of the when you interact with the patient, you realize the patient is having an open airway. Airway is patent. The patient is speaking with full sentences. Then breathing, our patient is having a respiratory rate of 28 breaths per minute. Our patient is also having SpO2 of 84. The 84 in room air. And then there is also use of accessory muscles. When I check the chest, there is reduced breath sounds, okay, with the freckles over the right upper lung. And this patient is having dullness over the right upper lung, okay? And there is no wheezing when I auscultate. There is no wheezing at all. So I'm going to proceed to check. Now, normally, just a second, normally when you are using this tool to assess the patient, you can intervene intervene as you assess, or if you are a pair of medics, you can assess as the other one is intervening, or I normally prefer to walk through as it is a quick primary survey, then I can intervene. So I'll proceed. That was for B. For C, I assess my patients. I see no jugular vein distension, no peripheral edema. The extremities are warm, but there is a delayed capillary refill of less than 3 seconds, and that's what you observe when you look at breathing. That's what we are observing. For saturation, like I said, no JVD, no peripheral edema. The extremities are warm, but there is a delayed capillary refill. Okay, so there is heart rate of 110 beats per minute, and then the BP is 98/62. No signs of active bleeding. That is for saturation. For disability, the glucose levels is 5.1 millimoles. And then the GCS is 15, and there is no focal deficits. When you export the patient is having a temperature of 37.8 degrees. And the patient is appearing wasted, no rash or trauma, The patient is having no signs of meningism and
So that was, thank you so much for that. We are going to go back to Dr. Patricia, and Dr. Patricia is going to add on to what Dennis has been telling us, practically what they found out concerning this patient. Yes, Dr. Patricia, you're welcome.
Thank you very much. So just a recap. On our primary survey, airway was patent. The patient was speaking with shortened sentences. On breathing, he was hypoxemic with a SpO2 of 84 on room air, tachypneic with a respiratory rate of 28, using accessory muscle. On percussion, we had dullness on the right upper lung. On auscultation, reduced breath sound, bronchial breathing, and crackle over the right upper lung. There was no wheezing, as you can see on the image beside. On circulation, the patient was tachycardic with a heart rate of 110 per minute, hypotensive with a BP of 98/62. Extremities were warm, regular pulse with a capillary refill time of less than 3 seconds. He had no jugular vein distension, no peripheral edema, no active bleeding. On disability, he was alert with a GCS of 15, no focal neurological deficit. His blood glucose was 5.1 millimole per liter. On exposure, he had a wasted appearance with a BMI of around 18, temperature of 37.8, low-grade fever, no evidence for rash, cyanosis, trauma, lymphadenopathy, extrapulmonary TB or meningism. So far, I would like to ask to the audience and the experts, what are the top 3 management priorities for this patient at the bedside?
So there is going to be a poll for the people that are in the chat. Kindly feel free to participate in this. Later on, we shall display the correct answers, and then you mark yourselves. Just have a few minutes for this.
While you're doing the poll, I'm just going to answer one of the questions in the chat around, is a blood pressure of 98/62 considered hypotension? I agree. It probably isn't. Especially in a young patient who's quite wasted. So this may be a good blood pressure walking around, but it is very patient dependent. So what is their normal blood pressure and how does this vary from their normal blood pressure? And also what the trend is of the blood pressure across time. So 98/62 might be borderline, but it does sort of just raise a flag of we need to keep an eye on this.
Thank you so much, Dr. Tracy. I think we are going to stop there with the poll and then go back to our presentation. Dr. Patricia.
Thank you very much for the answers. Our team has gathered 3 priorities: threat to breathing, severe hypoxemia, with an SpO2 of 84% on room air, tachypnea of 28, and use of accessory muscle, the associated risk being respiratory failure, tissue hypoxia. The immediate action taken was to put the patient on oxygen with nasal cannula 4 liters per minute, and it has improved to 94%. Threat to circulation, we had 2 priorities: early sepsis in view of the tachycardia, heart rate of 110, borderline BP 98/62, low-grade fever 37.8, with the associated risk being septic shock, organ dysfunction. Action taken: get 2 large bore cannula IV access, take blood sample for investigation, and start empiric antibiotics. Hypovolemia being the third priority, in view of his wasted appearance, malnutrition, mild hypotension, insensible losses, the associated risk being perfusion deficit and renal injury. Action taken: IV fluid resuscitation, but cautiously. Important to note is we have to reassess the response to treatment and monitor. Now, my question would be, what if our SpO2 does not improve? What do we do? What are the basic airway maneuvers and how do you perform them?
We are going to have a video for this and see some of the maneuvers. Yes, I can see some people participating in the chat, mentioning some of the maneuvers. Thank you so much, Emmanuel Opolot.
Video aims to show you the technique of chin lift, head tilt, and jaw thrust in both adults and children. Remember that having a dedicated person who can perform these basic airway skills well can make the difference in a patient's outcome and save their lives. This first video will be without audio. So again, the same video. The very large head and occiput of a child will automatically place them in a flex position, and this can compress their airway. You can use towels or sheets to raise the shoulder of young babies to compensate for their big occiput. You want the face to be parallel to the ceiling. Okay, this is well demonstrated in this image here of a very young infant who has a naturally flexed position of their head. The large tongue falls back against the nasopharynx. And you remember that all children up until the age of 6 months only breathe through their nose. This allows them to breastfeed. So if this pathway is collapsed, you are actually obstructing the airway. The airway can be best opened in both adults and children by placing them into this sniffing position. There are 3 main components that you want to assess for. The first one we already talked about, having the face horizontally aligned with the ceiling. So the chin and the forehead are in the same plane. By having a headrest or a shoulder roll, you actually allow the neck to open up, which gives more space for the mouth to open. This will help you with some of the procedures we're going to talk about later. The final component is to have the external auditory meatus horizontally aligned with the sternal notch. Again, this places the airway in the best position to allow it to remain open along its length. The next video we're going to talk about jaw thrust and chin lift. Again, the first video has no sound. Okay, the same video again this time. So first of all, we're going to look at chin lift. So with the chin lift, you need 2 fingers placed underneath the jaw, being very careful not to compress the soft underneath that will force the tongue against the top of the mouth. Counter pressure is applied with the palm on the forehead. For jaw thrust, you can place your thumb on the forehead, or you may not need to use your thumbs at all. Most importantly, avoid pushing on the eyes. You then use your index finger behind the angle of the jaw to lift the jaw towards the ceiling. So we've gone over head tilt chin lift and jaw thrust in a pediatric patient. How does this look in an adult? Again, looking at this video without any sound. Okay, repeating the same thing. The same technique really exists for the pediatric patient with regards to the chin lift and head tilt. So you're going to come in with 2 fingers underneath the chin, the head against the forehead, and you're going to rotate to lift the chin up. You will not be doing this where you suspect a cervical spine injury. For jaw thrust, the thumb goes on the zygoma or the cheekbones, and you lift from behind the angle of the jaw forward so that you can bring the jaw up towards the ceiling. You can also use your index fingers in a pistol grip where you use your knuckle behind the angle of the jaw. I find that this is better for patients that, or for doctors that don't have good hand strength. So what does this look like in real life? This is an MRI video I want you first of all to pay attention to the airway. Watch how the tongue comes right off the back of the airway and everything clearly opens up. However, when you pay attention to the spine, when you are doing a head tilt chin lift, you can see how much the spine moves. And this is why we don't recommend this in a trauma patient. So that was chin lift, head tilt, and jaw thrust in both adults and children.
Thank you so much. That was the video. I hope you have been able to pick something. Those are very, very important techniques that can change a lot when we are managing such critical patients. We are going to go back to our presentation. And now that we are almost stabilizing our patient, there are other things now we need to also get to know, find out, and do. Dr. Patricia, you're most welcome.
Thank you very much. As you said it, we have stabilized the patient, titrated oxygen, started IV fluid and empiric IV antibiotics. What's next? Let's gather more details.
Just a minute, Dr. Patricia. And if you have any questions concerning the video we've just watched, feel free to type in the chat. We are getting all these questions. At an opportune time, we shall have them read out, and our experts will be giving us the timely responses. Yes, Dr. Patricia.
Thank you. Let's continue with more details. We'll go to a sample history. As for signs and symptoms that we have talked about earlier, difficulty in breathing, progressive, now at rest, dry cough, reduced appetite, weight loss, nootopnea, wheeze, hemoptysis, leg swelling. A for allergy, no known drug or food allergy. M for medication, he's a known HIV positive but not currently taking any medication. Mentioned that previously he has been on antiretroviral therapy with tenofovir, lamivudine, and efavirenz, stopped 6 months ago due to side effects, and he's not on cotrimoxazole. P for past medical history. For him, HIV known for 4 years, last CD4 8 months ago, 180 cells per millimeter cube. Last oral intake has been feeding poorly for the last 2 weeks with porridge and tea. The event leading up to presentation is the worsening of the difficulty in breathing over the last 24 hours. No trauma or no travel mentioned. So, with all these new details, what are all the possible differentials and what will you be looking for in examination to support this? Audience? Expert? What do you think?
Let's have 2 or 3 people from the audience give us their opinions before we can have the experts. Feel free to put up your hand and we pick on you.
I've seen a couple of responses in the chat. We're seeing some PJP, TB, pleural effusion, septic shock, hypoglycemia, pneumonia, severe pneumonia. RDS, PE, MI, COPD, empyema, now we're getting great, some really lateral thinking. Okay.
It's quite a long list.
Yeah.
The differentials can keep coming. I don't know if our experts have something to also add on.
Yeah, I'd be happy to say something. So whenever I'm thinking about differentials, I like to have a structured approach to my differentials. And I agree with everything that everyone is saying in the chat there. But to make sure that you don't get too focused in on what might seem like the most obvious diagnoses, use some sort of way of forcing yourself to think more broadly. So one of the mnemonics that we use here, and if you're a person that likes mnemonics, is vitamin. And I will pop that into the chat for you guys to have a look at. But basically thinking of things like vascular causes, so a PE or cardiac failure, thinking of things that might be infectious. So I think we've covered off on a lot of infectious type of causes there. But also like the really atypical ones. So I saw some atypical causes up the top there. Trauma and toxins, so things like cyanide or carbon monoxide that might make you feel short of breath, autoimmune diseases, so things that we wouldn't necessarily be able to initially see at the bedside, but you need to think more broadly, especially if they don't respond to treatment like you think. Metabolic causes, so an underlying DKA can certainly make someone look like they're short of breath. Iatrogenic causes, so things that we do to patients, like giving them the wrong drug. And neoplastic causes such as lung cancer or metastatic disease. So I think we've had some fabulous things at the top there, just encouraging you to think a bit more broadly. And yes, don't forget COVID-19. And yes, advanced HIV disease would come under the infectious causes. So that infectious list will be quite broad. Thank you.
Yes, thank you so much, Dr. Tracy. We are going to go back to the presentation. Dr. Patricia.
Thank you very much, Dr. Tracy. Thank you very much to the audience. We are very interactive. We like that. So this takes us to the secondary survey. And we have categorized it in two, relevant positives and relevant negatives. We have a 48 years old man, known HIV, presenting with sick-looking, wasted, sweaty, dry mucosae, mild conjunctival pallor, mild shortness of breath at rest, abnormal sound over the right upper lung. But he's alert, with normal conscious state. He's weak. He has a mild muscle weakness, 4+/5 globally. He has responded to oxygen and initial fluid treatment with a heart rate of 100 now, SpO2 of 94 on 4 liters on non-rebreather, on nasal pumps. Sorry. Relevant negative, he has no murmur, no sign of fluid overload, normal abdomen tenderness, no organomegaly. He has no phoconeurologic deficit. He has no skin lesion or ulcers, especially looking for features of Kaposi sarcoma, no lymphadenopathy. Now, what do we have on investigation? We are in the ED, so the first thing to do is a bedside exam, we started with the ultrasound, point of care ultrasound, focus. Our foci, remember our trait on breathing and circulation, so lungs and heart. On the lung, we have on the right upper lobe a subpleural consolidation, as you can see on the image here. This signifies that instead of having air around the lung, we have something else like fluid, pus, cells, anything. But the ultrasound is normal elsewhere. On cardiac focus, the heart is normal and the pericardium too. But we have a collapsing IVC for more than 50%. This means that the patient is volume depleted. Action to be taken. I hope the audience has some idea there. Let's continue with investigation. Next on the list, chest X-ray. As you can see here, I hope it's clear. We have cavitating lesion on the right upper lobe with patchy infiltrate. Sputum for gene expert shows MTB and rifampicin sensitive. Our CBC showed an anemia of 10.2 gram per deciliter. Platelet normal, white blood count normal. Malaria ARDT was negative. Random blood sugar 5.1, ESR 78, ECG showing a sinus tachycardia. Electrolyte, we have a hyponatremia of 129. Potassium and creatinine were normal. Results for CD4 count are still pending. ABGs, VBGs were not done. CRP, D-dimer, not done. LFTs pending. Blood culture pending too. Audience, what do you think? Differentials. Dear audience, dear experts, any idea? Is there something new that came up?
Yeah, there are differentials coming up in the chart. Can see the list is now a bit narrow. PTB, someone is saying, David says PJP still stands. PTB anemia, HD, advanced HIV disease. So yeah, so I think we can go on.
Thank you. On our list, we have pulmonary tuberculosis as the first differential. We thought of pneumocystis jirovecii pneumonia too as an opportunistic infection. A patient who is not adherent to his ART treatment for the last 6 months, immunosuppressed, community-acquired bacterial pneumonia with early signs of sepsis, respiratory being the source, HIV-associated wasting syndrome, weight loss of 5 kg during the last 2 months, Anemia-related dyspnea, not the primary diagnosis, but still we have an anemia of 10.2. Disseminated fungal infection, immunosuppressed patient. Pulmonary embolism, not ANCA. It can be there in our patient. It's still the last on our list. And I'm happy to see that the audience have many ideas. The list is long in the chat. Thank you. Next step, supportive management. We talked about oxygen therapy, replacing fluid, and planning to switch to oral fluid as soon as the patient is able to tolerate it. Antipyretic with paracetamol, very important. Assess for response to treatment and monitoring of vitals, which the nursing management we talk about. Involved earlier the nutritional and social workers for nutritional support, vitamin supplementation, and ART adherence support. Back to our differential specific management. We had gene expert confirmed for TB. So start HRZE, isoniazid, rifampicin, ethambutol, pyrazinamide. An intensive regimen for 2 months has to be administered according to the weight band dosing. Suspected PCP, pneumonia, HIV plus hypoxia and dry cough. Start IV cotrimoxazole 906 and 60 milligram every 8 hours. Consider adding prednisolone 40 milligram PO twice a day for 5 days with a SpO2 of less than 90%, then taper down if there is no contraindication. Bacteria superinfection, add ceftriaxone 2 gram IV once daily and azithromycin 500 PO once daily. Then last and important, what's the disposition plan? Transfer to internal medicine, specifically in the TB isolation. Continue treatment and follow up the test results. Monitor for drug adverse reaction. We will recommend a delay ART for 2 to 4 weeks with the consult of HIV and TB clinic. Thank you. Let's continue with the nursing perspective of our management.
Thank you, Patricia, for your comments. Moderator, maybe I come in a bit for the questions and see if you can answer them. We still have some bit of time. Just 3 p.m. If that's okay with you. Thank you. Moderator, am I allowed? Please.
So I might jump in while we're just waiting for the slides to work out at the other end. There's been a couple of great questions in the chat, one around the fluid management. So remember, this patient's malnourished, they're likely to have a low albumin, and they're probably quite wasted. So we don't want to give too much fluid too quickly. So This is why Patricia mentioned to give cautious fluid challenges. The reason being, the way you're going to do that is that in a normal adult, you could probably give 2 litres straight up and they would manage that quite well. But in someone who is already under stress and doesn't have a lot of albumin in their system to hold the fluid intravascularly, then you want to just give a bolus of 250 to 500 mils and reassess their response. What is happening to their blood pressure? What is happening to their SATs? What is happening to their lungs? Listen to their lungs. And if you are skilled in bedside focus, then you can do a reassessment of their IVC as well. So I thought that was a really good point to highlight.
Yeah, well, thank you all. At this moment, we are going to hear from a nursing perspective, and we are going to have our nursing care plan to the 48-year-old male presenting with difficulty in breathing. I hope our participants have been much active and attentive. But for those who just join us, I'll go through briefly in the nursing assessment, whereby we shall look at the subjective data and the objective data briefly, and then we shall continue. In our subjective data, we're looking at the patient's complaints. We saw it in the presentations, saying our patient had dry cough, reduced appetite, chest pain, had fatigue, and fever. Whereas in our objective, we saw our patient, this is what we saw from the patient, having difficulty with breathing. We saw it from our video. Loss of weight, about 5 kilograms. Use of accessory muscles, and then pale conjunctiva. Now vitals, yes, which is so wanting and needs urgent attention. Look at blood pressures being quite low, 98 over 62. Heart rate being above normal, 110 beats per minute. Temperatures quite high, 37.8 degrees Celsius. And our respiratory rate of 28 beats per minute. Our focus is now the SpO2, which is low, 84% on room air. In our lab test and imagings, briefly, we saw most of these tests being done. Chest X-ray done, sputum for genetic expert, full blood count, RBS, which is 5.1. The ESR done, ECG, we saw it. MRDT, urea, electrolytes, and creatinine done. Whereas these are the pending test. A CD4 count, which is very important, we need to know about it. The arterial blood gas, still pending. CRP, and then D-dimers, not yet done. RFTs, and then lastly, the blood cultures. I'll go take you straight away to our nursing diagnosis. As per our patient, we can form as many nursing diagnoses as possible. But for now, we're looking at our focus as difficulty in breathing. So I have one nursing diagnosis. And this is our nursing diagnosis. Ineffective breathing patterns related to opportunistic infections. And here we're saying suspected PCP, which is evidenced by use of accessory muscles. We saw tachypnea, and then reduced oxygen saturations of 84% on room air. We can continue. In our goal or the desired outcomes, we're saying to improve or restore adequate oxygen levels to the vital organs within 24 hours. And then secondly, is to improve hypoxia within 2 hours. In our nursing intervention, this one basically nurses and midwives should emphasize. This is our role now, where we come in and then we do the basic nursing care. We've seen our patient have a difficulty in breathing. First and foremost, we have had in airway, and the focus is now in breathing, where we're going to administer oxygen, that is 3 to 5 liters per minute via a nasal cannula. Secondly, we're going to position our patient in a sitting up positions. Thirdly, I saw in the charts why art is being delayed. Here we are starting on art, administer or start patient on art as prescribed. And for this case, we shall give it on dot. We, the nurses and midwives, we're going to give this patient, and we have to ensure the patient takes the medicines as we are seeing. And then our worry was somewhere in the blood pressures. Yes, here we're going to access a big bowel cannulas, and we're going to administer IV fluids, preferably normal saline, 0.9%, to restore and improve the blood pressures, which is 98/62 to about 120/60 millimoles of mercury within 2 to 4 hours. Next, we're going to administer antibiotics, and this time we're going to give paracetamol, which should be able to reduce our temperatures to normals. Start on anti-TBs immediately, and anti-TBs we match where we give it on dot. The nurses and the midwives will give these drugs as we are seeing. Don't give the patient the medicine and say, you take. No, it is a way to give on dot. Next, going to administer antibiotics. Of course, our patient, we have much suspicious of sepsis, and preferably as prescribed by the doctor, we saw ceftriaxone, and if our patient can tolerate oral or per oral, we're going to give azithromycin. Then we're going to have advice on nutrition as per the nutritionist consult, very important. Others that we might also need to take care of, look at the oral care, very important. The patient have to feel comfortable. Hygiene of the patient, bed bath, we need to emphasize, need to ensure the bowel care, our patient is able to pass on stool very well as catheter cares. Those are our interventions as nurses and midwives. Why are we doing all this? The rationale. One, we saw we're saying to restore and improve adequate oxygen levels to above 95%. And we saw our patient having a low SpO2 of 84. Therefore, we gave oxygen, so we expect our oxygen levels to be above 95%. Position our patient in a position to improve good perfusions to the vital organs. Next, we are going to add drugs was given to preserve immune functions. IV normal saline 0.9% to improve on blood pressure, and antibiotic to reduce on body temperatures. Anti-TBs, basically no, we're going to have our emphasis to cure the TB. Next. Antibiotics, there was high suspicion of sepsis. That's why we are going to administer antibiotics as prescribed by the physician. Next. Good nutrition to support antiretroviral therapy. Very important. As our patients are taking the ARVs or the ART drugs, we have to ensure they have good nutrition. Now, therefore, lastly, we're going to look at our evaluations, how best we have done, and what can we improve. Saying oxygen levels, we have seen being improved from 84 to above 92%. And we're seeing our patient breathing has improved while in sitting positions. Next. Patient immune functions preserved, and which is still ongoing. Next. Which is ongoing. Then we have improved normal body temperatures, which is controlled. We've seen that. The RTBs, which we administered, RTB regimen is still ongoing. And then the antibiotic treatment for sepsis as well still ongoing. Then lastly, patient nutrition as well still ongoing, and therefore we shall keep on getting advice from the nutritionists. Thank you so much for listening.
Thank you so much, Mr. Gal, for that wonderful discussion. We are going to now go on to our next session. And here we are going to have Dr. Tracy, an emergency physician at Mbarara University of Science and Technology. And he's going to be taking us through the emergency medical management of a patient with severe difficulty in breathing. If you have any questions, like I said, when we had just started, feel free to put them in the chat. We are going to have time and respond to all of them. Dr. Tracy, you're most welcome. Kindly feel free to come on board and make the presentation.
Thank you. I think we're going to have a couple more skill sessions that we've pre-recorded for you. I just want to take this opportunity to bring out a couple of the other conversations that are being had in the chat. I'm really loving the input from everyone in the discussion. So thank you for your assistance in the chat. So one of the questions was around, why do we give antibiotics and steroids in this patient when it looks like they clearly have a TB on the both the gene expert and the chest X-ray. And this was definitely something that we as a group also discussed as well. I think that my initial reaction is that, this patient has quite classic signs for TB. I don't think anyone's disputing the fact that you need to treat that. Do we need to treat PJP? So typically in my experience, the patients with PJP come in quite hypoxic and don't correct particularly quickly with oxygen supplementation. But I think that having co-infection in someone who is immunosuppressed was one of the discussion points that came out, and that we went back and did a little bit more reading around. So the recommendations are that even if that patient looks like a TB, you still start them on the PJP treatment until proven otherwise. In that, because that is going to be a very different management strategy with the addition of the steroids as well. Did any of the other experts have anything that they wanted to add on that point? And I think also in the chat a couple of times, the question about the timing of recommencing ART in the context of someone with TB has come up as well. And yes, we agree that it should be delayed for a couple of weeks because of the risk of immune reconstitution syndrome that will actually cause the patient to deteriorate despite treatment. Anything else before we move on?
I think at this point we can request Darlington if he has spotted any of these questions that have not been responded to yet, to bring them on board, and then we'll have them attended to before we can proceed to our next session. Darlington?
Yeah, sure. Yes, good afternoon. I hope I'm audible. Yes, most of them have actually been answered in the chat question, but in the interest of this discussion and also possible future discussions, somebody wanted to know protocols for transporting patients with airway or breathing emergencies. I think our colleague of pre-hospital touched on some of them, but we can still maybe, specify on that. There was an issue of Anasaka and hypertension and DIB, and also the need for needing to know about CPAP, but maybe might not be part of this discussion. Airway management in a collapsed patient. I think we've seen that we are going to see it with the skill sessions with devices. We already saw maneuvers. Then there was a particular question from Pius Mukasamulumba. Thank you for the question. I think this was a case scenario that has happened to him previously. He had an issue stabilizing a very critically ill patient with difficulty in breathing. Oxygen starts not coming up on high flow oxygen, and he had other interventions, including nebulization with salbutamol and steroids in a patient who he says had been diagnosed with malaria and pneumonia, but the patient eventually succumbed after 48 hours. That was quite a difficult case from what I could see. So personally, I would still do the ABCDE. And in this case, I think this is somebody who probably needed advanced airway support, depending on their presentation. But to me, this is what I see. And then also, of course, if it were possible to find a way of that stabilization and then eventual admission to an ICU. So he was quite a critically ill patient. But again, remember, these patients are dealt to on in the patient case situation. So patient dynamics differ, so we cannot really say that this one worked for this, it would work for the other. But yes, be able to use the ABCDE and see which interventions are particularly needed for this particular patient. I don't know if Mr. Mukasa, you also made a diagnosis of COVID in that patient, or maybe as we saw in this particular case, the list can be long. Then somebody needed to know about BLS and skills where to get them. There are people who provide BLS skills. I'm not so sure this is the right forum for them, but I'm sure we'll find out. And if we need to tell you, then we'll do that. We looked at the maneuvers, head tilt, jaw thrust, both in adult and also in PIDS. There was a particular question about a patient without a mandible, which was addressed. You still sit them up if they can be able to support their airway, and maybe support them to sit up if you can. Then I think in a session coming up, we shall see about the nasopharyngeal airway, which could be used in such a circumstance. And then Sylvia Mikali wanted to know when to use an OPA or NPA. I think that is coming up. On OPA is oropharyngeal, NPA is nasopharyngeal. The different diagnosis of the case we had were quite a number. We got a good mnemonic that you can always refer to, especially those exam amendments for maybe the students and others. the vitamin, and other acronyms that are involved. Niwamanya David wanted to know the CD4 count. That was said we didn't have it at the time of presentation. I hope they have it now, and they can tailor treatment to that. Cynthia Slivia again wanted to know how much fluid to give to avoid cardiac overload. Yes, I saw an answer to that in the chat, but also to know that you need to also know why you're giving fluid and what targets you're looking at, so you do not, your work is towards meeting those targets per patient dynamics again, and not to overshoot them.
Yes, Darlington.
Amos, I'm done almost, just a minute. PJP, that was answered. So I think also the other question on antibiotics was answered. So for now, I think we can proceed with input from Dr. Tracy. And if anything else has not been cleared and comes up, then we can always capture it. Thank you.
Thank you so much, Darlington. And the people submitting these questions in the chat.
Yes, it's very interactive. Thank you.
Yeah, it's quite interactive. We are going to watch a video.
This video will demonstrate the correct sizing and insertion of a nasopharyngeal and oropharyngeal airway. Nasopharyngeal airways come in a variety of sizes in terms of width and length, but they all will typically have a flange at one end, which will stop the tube from being lost down into the nasopharynx, and a beveled edge at the other end. When inserted, the nasopharyngeal tube should run horizontally through the nasal passage and then take a turn around the back of the nasopharynx to sit posterior to the tongue, just above the epiglottis and laryngeal inlet. It is very important to note that this is a horizontal pathway, as it will change how you actually insert the NPA. So when you are sizing a nasopharyngeal airway, there are two components. You want to look at the width, does it fit into the nose, and the length. The length should be from the nose, from the nares to the tragus. And you can see here that this is patently too large, well and truly passes the tragus. This one is not too bad, but perhaps is just a little bit too long. Whereas this one fits quite nicely and will sit just posterior to the tongue. So we're going to use this one to demonstrate. The first demonstration will be without audio. Okay, repeating that, we're going to insert the nasopharyngeal airway so that it follows the natural curve of the actual tube. The bevel, you apply some lubricant, and the bevel should face flat against the septum. Once you're insert a directory to a more horizontal position along the nasal passage, you're going to hang up as it passes around the back of the nasopharynx and into the posterior tongue position. In a dummy like this, you need to use much more pressure than you would in a patient in real life. The oropharyngeal airway has a similar structure, but obviously this time we're going through the mouth. It also has a flange at the end just to act as a bit of a break. The coloured part that is demonstrated on these oropharyngeal airways sits between the teeth and acts like a bite block. The curved component makes an open airway that runs over the tongue and sits at the base of the tongue. When sizing an oropharyngeal airway, there are a number of techniques. I use a midline approach from the central incisor to the angle of the jaw, and again, following the natural curve of the airway. You can see here that this is way too small. This is getting closer. This one sits quite nicely at the angle of the jaw, and I'm just going to check the next size up, which is too large. It passes the angle of the jaw. So just without audio for a moment. Okay, insertion with audio. So what you want to do is you need to insert you're going to start by inserting the OPA upside down over the tongue, and then once you're halfway down the hard palate, you take a 180-degree turn and complete the insertion over the base of the tongue. Now you will have a patent airway and you can perform your bag valve mask ventilation through this airway. The technique is different in children. You want to use something like a tongue depressor, and you do not rotate. You directly insert over the tongue without any rotation. Do not twist or turn the OPA in a pediatric patient. The reason being is their hard palate is very easily damaged and you can actually cause bleeding. Also note that even in an adult patient, if the patient begins to gag, then remove the OPA. They will not tolerate the OPA, they will vomit, and this will further soil your airway, making it more problematic than it was to begin with. This is also the reason why you need an appropriately sized OPA so it doesn't stimulate the very posterior nasopharynx and obstruct the larynx. So that is an NPA and OPA insertion.
That was our video. Now we are going to have a second poll. Feel free to participate. We are going to display the answers later. So we are going to end our poll, and then we are going to watch another video. If you suspect tension pneumothorax, do you actually know what to do? And we are going to learn. Anyway, think through it even before the video is displayed. If you are encountering a patient who you suspect or who you've actually confirmed to have a tension pneumothorax, what would your next step be?
This is a video to guide you through the process of performing a needle thoracostomy. This is a life-saving procedure to relieve tension pneumothorax. As a reminder, a tension pneumothorax occurs when there is a one-way valve formed between the visceral and parietal pleura. This allows air into the pleural space, and that air will build up. As the air quantity increases, then the pressure will also increase as well, which will compress the lung on the same side and also compress the mediastinum and push across to the other side when it becomes large enough. You might see something like this on a chest x-ray. So the features here are a shift of the trachea off to the opposite side of the tension pneumothorax. You can see the very prominent right heart border along this whole way. You can see lung markings throughout this side, but no lung markings on this side. It's very dark and hypodense. The actual lung is here. It's collapsed down completely against the heart border. You can also see that these ribs look a lot more horizontal and spread out. So that whole left chest is hyperexpanded. When air can't get into this lung, this patient will become hypoxic. When blood can't circulate through the lungs normally and get back to the right heart, then you will become hypotensive. So although it's great to be able to identify these features on a chest x-ray, a tension pneumothorax is a clinical diagnosis. The patient will look like they have air hunger. They will be hypoxic, they will be hypotensive, and their affected side will be hyperexpanded and hyperresonant to percussion. Here's a quick video that I'm going to show you the marking out for your location for a second intercostal space mid-axillary line. It's extremely important that you go through the process of palpating for the landmarks. Studies have shown that clinicians are notoriously inaccurate when they actually try to do it by eyeball alone. So you can see this one study showed that the clinicians inevitably went far too medially compared to where their target zone would actually be. So this puts you at risk of hitting structures like the internal mammary artery and causing a hemothorax as well as hitting other mediastinal structures. So it's very important to know to palpate out your landmarks. We'll go through this again in a moment. I also want to highlight that when you're in that rib space, that second intercostal space, you are in the very lowest part of that rib space, hitting the third rib. So you really want to be at the top of that rib. So the reason for this is because in most people, not in all people, but in most people, the nerves and the blood vessels run on the underneath of the ribs. And this gives you the best opportunity of not causing vessel or nerve damage. Again, I'm just going to show you in more detail. So you're actually going to palpate out the clavicle heads. You're going to find the midline and you're going to work out where that midline is as you move down from the first to the second intercostal space. And then you're going to use that as your target. You'll need to use a large bore needle. A 16 or a 14 would be ideal, but 16 is most available. I like to use the syringe filled with saline on the end of my needle for the reason that you just saw there. When you enter into the pleural space, you'll actually get bubbling of that air. So it will actually give you direct visual feedback that you have achieved your needle tip in the right position in the pleural space. So just going to go through that technique with a quick video without audio. Okay, noting the limitations of the model that I'm using. When you are perpendicular to the chest wall at the upper border of the rib, you enter into the space. As you are aspirating and get bubbles back, you know you're in the right space, at which point you're going to advance the plastic cannula and remove the needle. You should get ongoing hissing or sounds feedback that you are in the correct space. There are a number of things that can go wrong with a needle thoracostomy. You can end up with a false feedback that you've got air because you've actually hit subcutaneous air bubbles. If you've ever seen a patient with a massive pneumothorax, you know that they often have a lot of subcutaneous emphysema, and it might actually be that that's giving you false reassurance you're in the right place. If your needle's not long enough, you might end up in the subcutaneous tissue. If you have gone too far and you're in the lung, then you will still get air back, but you will get closing off of the tissue around the end of your needle, and it won't fully drain the pneumothorax, or indeed you might actually hit a blood vessel, either the internal mammary that we already talked about or another blood vessel in the lung itself. So you might get blood back rather than air. So you can see that there's many possibilities as opposed to just getting yourself into that intrapleural cavity. In patients who have a larger body habitus, there is some evidence to suggest that we should be using the same location that you actually would normally use for a intercostal catheter, a formal chest tube. So that's the anterior axillary line in the 4th or 5th intercostal space. The reason for this is that there's been a number of CT, ultrasound, and cadaver studies that have looked at the thickness of the chest wall at this site compared to the mid-clavicular line, and has shown consistently that this area does appear to be thinner. So if you have a shorter needle, then you have a better opportunity of reaching the intrapleural space. Or if you have a larger patient, their chest wall is going to be thinnest at this site. This is a video that shows this same procedure. 4th or 5th intercostal space, anterior axillary line. So how do you know you've been successful? You could get a hissing sound, but if you've got the needle with a syringe of saline on the end of it, then you'll get bubbling instead. And that can be useful because if you have a very noisy environment, that hissing sound can be hard to hear. But what you absolutely should have if you have a tension pneumothorax and you've treated it correctly is there should be an improvement in saturations, there should be an improvement in conscious state, and an improvement in their circulatory status if that's their only issue. You've now saved a life, okay, and you've bought yourself some time, but all needle thoracostomies must be followed up by a formal intercostal catheter at some point when you have the time, expertise, and number of people available to perform that procedure. So that's the needle thoracostomy for tension pneumothoraces.
That was the session. Dr. Tracy, do you want to give any submissions before we play our next video? To the audience, we have a video where we are going to look at three-sided dressing for sunken chest wall. Dr. Tracy, do we play that video right away, or you want to first add on?
I'll just, I liked the question that was put into the chat about do you use local anesthetic, and it's a very, it may sound like a callous response, but you know, this is a life-threatening condition. You do not have time to put in local anesthetic. You do the procedure, you save the life, and then you apologize that you hurt the patient. So please just know that this is a time-critical response. This is a super quick video discussing the three-sided dressing for an open pneumothorax, or otherwise known as a sucking chest wound. So when a patient has a penetrating chest trauma, they will have an open conduit for air to enter into the chest cavity and leave without anything to stop it. So the idea of a three-sided dressing is that it provides some protection against that happening. So the first thing that you're going to need to have for a three-sided dressing is an occlusive material, something that doesn't allow air through it. So Vaseline gauze packets are quite handy because they're quite foil-like, or you can use the plastic of another piece of material, as long as it doesn't allow air through the actual material itself. You're going to then apply that over the actual chest wound itself. Once you have that in place, then you need 3 pieces of tape or strapping to hold it down. The ideal is to have the 3 sides completely occluded, with the most dependent side left open to allow air and other fluids to escape. So the point here is that you create basically a one-way valve that allows air to move out and fluids to move out, but not further air to accumulate inside the chest wall cavity. So this becomes a little bit like a Heimlich valve. So when the patient breathes in, it closes the third or the open edge, and when they breathe out, it allows movement of air and fluid to come out of the open side of the three-sided dressing. The next video is a little bit dramatic, just to warn you, but it shows you the bubbling and the bleeding that will occur with a sucking chest wound. The good thing is, if you have bubbling and bleeding, you definitely know you do not have a tension pneumothorax. It can be quite difficult, as you can see, with the amount of fluid that is accumulated to get the strapping to stick to the patient. So this video is taken from the military setting, and a lot of the evidence around trauma care does come from the military setting. And they have moved away from, the most current recommendations have moved away from the three-sided dressing, because there is no evidence base to actually say that it is superior in any way to putting a complete dressing over them. So in the military setting, they are currently using fully occlusive materials to cover over the chest wound, and if and then a tension pneumothorax develops as indicated by what we talked about in the previous video, so hypotension, hypoxia, air hunger, and a hyperresonant unilateral hyperexpanded chest, then you go through the procedure of relieving a tension pneumothorax. So open pneumothoraces themselves can look very dramatic. They're very easy to see, but they are somewhat reassuring. Tension pneumothorax, however, can kill quietly unless you are looking for it and examining for the signs that lead you to suspect a tension pneumothorax, which should prompt you to do a decompression and chest tube as discussed previously. So that's the current evidence and approach to a three-sided dressing for an open pneumothorax.
Yes, so we are going to have for the next few minutes questions and answers, but before we go, we open up the chat questions or to the rest of the audience to ask their questions. There are some questions which have been asked, and I'm going to invite Dr. Tracy to make some comments. People are wondering if there is need for local anesthesia for decompression. What happens when you puncture the lung in an attempt to decompress? Is there a need for an underwater seal drainage for tension pneumothorax? And how soon should one repeat an X-ray of the chest after a needle thoracotomy? For those wondering about the CPID link, it's going to be shared shortly towards the end. Dr. Tracy, you're most welcome.
Thank you. I've been trying to keep up with the questions, but they're coming thick and fast, so I will try and remember. I think we answered the local anaesthetic question. The question about an underwater seal drain. So as soon as you're putting in a chest tube, then it needs to be on an underwater seal drain. The needle decompression is a temporizing procedure. It is not a definitive procedure. So it's only to get you to keep the patient alive until you can perform a chest tube. So yeah, the chest tube needs an underwater seal drain. How soon should you repeat a chest X-ray after a needle thoracotomy? Again, same issue. It's temporizing. It's not the definitive treatment. The thing that you should be asking yourself more is, how did the patient respond to my intervention? Did their SATs improve? Did their conscious state improve? Did their blood pressure improve? If it hasn't, then you haven't fixed the problem. So you're not going to go on and do a chest X-ray until you fix the problem. So you need to reassess the chest, look for other issues. If you have not successfully relieved the tension pneumothorax because you had one of the complications that I showed in the video, it's gone into the lung and the lung has collapsed around the end of the needle, you've got bleeding because you've gone into a vessel, etc., then you may need to repeat the procedure. So either at the lateral to the same site at the second intercostal space mid-clavicular line, or in that fourth or fifth intercostal space anterior axillary line. And then what else did I miss? Was there another question in there that I missed?
There is one, I think, on for suctioning a patient who has just congestion. I think this is via ETT, or something like that, or another tube. Yeah. But it says the secretions are not reducing after, I think, normal saline for trying to loosen it up. Is it safe to use sodium bicarbonate? I think this is the second time this question is coming up, so I think somebody is really bothered. If you can have some pointers to it.
Yeah, so look, there's been a number of studies that have looked at, how do we sort of improve mobilizing patient secretions with various sort of nebulized solutions and steroids and hypertonic saline and bicarb, and none of them have really been shown to be of any great benefit. the main thing is going to be decreasing any bronchospasm if you have it, providing the CPAP, which is another lecture in and unto of itself. So I'm sorry, we won't get time to answer that question. Or things like actually, if you're using ketamine as a sedative medication, then that can actually increase your bronchorrhea, can cause fluid to be released into the lungs and can help loosen up the secretions. But I'm personally not aware of any evidence that any of the nebulized interventions actually increase or improve your ability to loosen up the secretions and suction the airway. I hope that answers that question.
Thank you so much, Dr. Tracy. I'm going to, I think most of the questions that have been posted in the chat have actually been responded to. I'm going to give an opportunity to the other panelists in the House to give us some of their remarks, concluding remarks in just a minute. And we will have a display of the poll questions so we can mark ourselves. And then later we'll also reveal the results. Yeah. So Mr. Joshua Ogal.
Yeah, thank you so much. Lastly, I want to emphasize it's about documentations. Very important. Nurses normally, after performing procedures, we fail to document. And even drug admin, we miss out. So my emphasis on documentations. Let us make documentation be part of us. Otherwise, I don't have much. Thank you.
Thank you so much.
Okay. Name again is Dennis Okalebo. I will emphasize the remarks that I made from the beginning, that sometimes emergency situations can be so intense that we forget the basics, but I would like to encourage us to always take care of our safety and not to forget to coordinate with the responsible people. We have a call center. If there is, or at least take initiative and communicate why you are taking these patients, lest you will take the patient and the facility that is supposed to receive this patient is not ready, and then the patient pays the price for our ignorance. And then also documenting. It is very key that we document everything that we do on a patient. I submit.
Yeah, thank you so much. Kindly feel free to take part in the quiz. It's been a wonderful session, and we have got to discuss lots and lots of things. And we have also had an opportunity to watch some of these skills practically. Those of us that joined in a bit late, we have had a case of someone who presented with difficulty in breathing. And it's very important that we think about the FDC first all the time. Airway, the breathing and circulation are really top priorities in such patients who present with difficulty in breathing. And we usually want to start with stabilizing them if they need oxygen, if we access the IV lines and always keep monitoring them. It's very important for us to keep reassessing these patients frequently after every intervention. We talked about the pre-hospital readiness, and this is also very important, and it actually saves lives. Early identification and proper preparation for transport is very important. You need to have the right staff, you need to have the right equipment, you should have oxygen. These are all very, very important. And you have to choose an appropriate transport modality for some of these patients based on the distance and the patient's stability status. Of course, we have challenges here and there. As health workers, sometimes you be in the hospital and you see multiply injured patient being brought in on a police kawangali. And that is sometimes disappointing, but where possible, we need to have those ambulance services, modern ambulances that can help us with this. And when we are assessing them, we use a structured kind of assessment approach where we do a primary survey for some of those life-threatening issues. And then later we take the history, remember that sample kind of history, and then a secondary survey to dig deeper into the causes of this difficulty in breathing. It's always very important not to skip some of these basic things, even when it's an emergency, because it's these small things that are actually life-saving in many of these situations. Bedside skills are very essential, and we have watched we've watched a couple of videos demonstrating some of these life-saving skills. It's very important for us to master these maneuvers because many of them are life-saving. So one should be comfortable with doing some of them, and also to know when to do some of those things. When approaching these cases, it's always good to have an open mind, because difficulty in breathing can present due to a number of pathologies, due to a number of causes. So think broadly, but also you have to be quite focused in your kind of thinking and approach. It could be an infectious cause, it can be cardiac origin, it can be pulmonary origin, it can be other things like anemia, and so on and so forth. It's also very important for us to be able to know and watch out for sudden deterioration of these patients, and what to do in case of that sudden deterioration. In case someone, for example, becomes hypoxic, all of a sudden becomes confused, all of a sudden becomes hypotensive, all of a sudden, what do you do next? And what do you think about what has caused this sudden deterioration? Is it a tension pneumothorax now? Is it a pulmonary embolism? Is it septic shock? And also be able to insert a needle. Those are some of the life-saving procedures, but are actually feared. Many people can't think about themselves as being able to do such procedures. But from the video we just watched, it is actually very feasible. The space where you put this needle is quite safe. Someone was asking, what if I puncture the lung? You're dealing with a tension pneumothorax, so most likely it has been pushed away. But so you are not, and remember, you're aspirating. Chances are high you're going to see those bubbles even before the needle advances very far. That space is quite safe. So you should, as long as you anticipate that this patient has a tension pneumo, you shouldn't think of it as a very complicated procedures. So, and the other thing is, we should also embrace the idea of an interdisciplinary kind of care approach. You involve the other teams. See, a patient might need to be initiated on ART, engage that team. Patient needs to be attended to by the surgical, medical teams, have them on board. And at the end of the day, we shall save these patients. You've been a good audience. We want to thank you so much. And I want to hand over to Dr. Tracy to take us through the polls and then also conclude the session. Dr. Tracy.
Thank you. I'm back. So I think the first poll we asked about what the first initial bedside steps were, and the vast majority of people responded titrate the oxygen, IV fluids, and empiric antibiotics. Those are the things that in a patient who is presenting with a suspected sepsis, you want to start with. So I think most people are on the right track there. Most of the other interventions weren't something that needed to be done now, and could have waited until those initial life threats were addressed. The second poll was, what differential diagnoses do you, sorry about background noise, do you need to consider in a patient who has a sudden deterioration? So yes, tension pneumothorax is absolutely one of them, but there are other things that can cause it. So PE, so if someone's suddenly thrown off a PE, they will also develop a shortness of breath, hypotension, and potentially confusion with that. And if they suddenly go into a cardiac arrhythmia, they're going to lose their cardiac output and become, potentially hypoxic from a lack of blood supply. So that was the answer to that question, which again, I think the vast majority of people answered. It was a bit of a trick question because, again, you've got to have a broad differential, but from an emergency perspective, what are the life threats that you need to be thinking about and addressing? And then this final question, what is not a basic airway maneuver? The Heimlich maneuver is not a basic airway maneuver. And I really think that we talked about head tilt, chin lift, we talked about jaw thrust, but we really underutilise the recovery position in hospitals. And I think that it is a great way when you have few staff to attend to a patient to have them in a recovery position and help open their airway. So it is definitely considered a basic airway manoeuvre. So thank you.
Thank you so much. There is someone who has been putting up their hand for a very long time. Wani Patrick, I hope you're still there. We are going to ask you to unmute. And so you say your pressing issue in just a few seconds, less than 20. As he unmutes, we shall also request that we put